A very good evening to all the doctor fraternity present over here for attending the live webinar on the topic vulvovaginal infections, treatment and protocol strategies. Vulvovaginal infection is a major challenge which is often misdiagnosed, leading to inappropriate treatment, especially in resource-constrained developing countries. Precise diagnosis of VVC confirmed by examination and culture is a challenge due to heavy OPD in day-to-day clinic. Under the present scenario, doctors are experimenting with the newer options over conventional and gold standard treatment on patients as the ground for this is yet unknown. So to raise concerns on this topic, we have world eminent and highly researched Dr. Jack Sobel with extensive contribution in this field amongst us who will share his wisdom to strike a balance with the gold standard treatment for effective treatment outcomes against vulvovaginal infection. So before I hand over the session to Dr. Kiran Coelho, I would like to introduce Dr. Kiran Coelho. So, Dr. Kiran Coelho is the head of department from Lilavati Hospital and Research Center, Mumbai. She is the honorary consultant from Hinduja Healthcare, Surgical and Holy Family Hospital. She is the member and the managing committee of the IAGE, and she has also been the prior assistant professor at TN Medical College and BYL Nair Hospital. She has practiced minimally invasive surgery and has trained more than 500 gynecologists in the gynecendoscopy. Currently, she is a teacher who has experience of more than 40 years, and she has also been felicitated by the Guinness Book of World Records for world's largest health talk on breast cancer awareness 2020. So welcome Dr. Kiran Coelho on board. I hand over the session to you, ma'am.
Thank you so much, Bharat, and good evening, all you doctors all over. I'm sure you're waiting to hear our speaker, Dr. Jack Sobel. May I have his resume? We are all waiting to hear from the oracle of vaginal infections. So it's my great privilege and pleasure to introduce Dr. Jack Sobel, who's an MD professor of internal medicine, the Dean and Professor of the Wayne State University School of Medicine, and Chairman from the Wayne State University Physician Group. He's a research fellow in infectious diseases, Laboratory of Clinical Investigation, National Institute of Allergic and Infectious Diseases, with the National Institutes of Health, and as a fellow in infectious diseases at the Medical College of Pennsylvania. He served as the Associate Chair of Research in the Department of Internal Medicine before being named Chairman of Internal Medicine in 2014. He's a professor of internal medicine, immunology, and microbiology, obstetrics and gynecology, and is one of the world's foremost authority on bacterial vaginosis with more than 172 publications. Welcome, Dr. Jack Sobel. We are all waiting with bated breath to hear your talk.
Good evening, everybody. Excuse me. It's a pleasure to have this opportunity to discuss the treatment of vulvovaginal candidiasis in particular, but I'm going to spend a few minutes to discuss pathogenesis and diagnosis before coming to treatment, because this is so critical to having an understanding of what we can expect in treatment. So just to remind everybody, next slide please, that the global burden of Candida vaginitis is that millions and millions of women affecting all strata of society will suffer from Candida vaginitis. In particular, when we look at women who are very prone to Candida vaginitis and who have 3 or more attacks per year. This may involve millions of women worldwide, a range of 100 to 172 million women. And this clearly has an enormous impact and an enormous economic burden on every country worldwide. Next slide, please. So just to remind you that by far the dominant pathogen, the cause of Candida vaginitis and recurrent vulvovaginal candidiasis remains Candida albicans, although in some countries, the number of non-albicans Candida species increases. In North America, only 5 to 7% of vaginal infections are caused by Candida glabrata, and it is increased in other countries. Next slide, please. So this emphasis on distinguishing species is nevertheless important. The species vary in virulence, their ability to produce pathogenic factors to form hyphae, or as well, the spectrum of disease is different. Candida albicans is the most virulent and the most likely to cause vulvovitis, a vulvar disease involving the labia and hair-bearing skin, as well as the vaginal mucosa in its own right, whereas many of the non-albican species limit their pathology only to the vaginal cavity in its own right. The species significance is also borne out because not all these species, especially the non-albican Candida species, are susceptible to all the usual drugs we use in the treatment. Their ability to persist in the vagina after a course of therapy, in spite of therapy, also varies by species. So in women who have recurrent disease, chronic disease, it's very important to be aware of the species you are dealing with, not on a routine basis with every patient. Next slide, please. It's important to recognize that in the clinical practice, many doctors will make a diagnosis just on the basis of history and physical examination, nothing more. This results in a significant both overestimation and underestimation of the diagnosis. And what happens then is that the physician then recommends therapy, which we call empiric therapy. In other words, it's probably Candida, let's treat it for Candida, and without attempting to confirm the diagnosis. I want to make a plea for making every effort on the part of physicians to make an accurate diagnosis. POC stands for point of care. We believe the doctor should be able to make a diagnosis in minutes on the basis of the normal vaginal pH in Candida infections, the result of microscopy, and if necessary to get a culture. Cultures are not expensive compared to the more recently available molecular methodologies that are now available, where they do PCRs and DNA probes. And while these latter new molecular methods are now available and very sensitive and useful, they nevertheless are expensive. And they usually you don't get the result where within a matter of minutes. It may take several days. The gold standard, therefore, to all intents and purposes, for being certain what we are dealing with is therefore still a culture using traditional methods. Next slide, please. Couple of words about pathogenesis. Remember that the process starts with vaginal colonization. Candida albicans migrates from the lower genital tract to the vagina, where it colonizes achieves this colonization by attaching to the vaginal epithelial cells, a process that is facilitated by estrogen, and therefore we don't see Candida vaginitis in the pre-pubertal young girls, and we see it much less commonly postmenopausally, unless women are receiving hormone replacement therapy, estrogen replacement therapy. After colonization occurs, symptoms do not inevitably develop. There is a period of asymptomatic colonization which may last weeks, months, or even years, because the vagina normally tolerates the presence of Candida in relatively small numbers in the vagina. There isn't an immediate inflammatory reaction. However, in other words, the vagina physiologically tolerates the presence of Candida organisms in the vagina in small numbers, especially if there's no hyphal production. Certain behavioral triggers promote or allows Candida albicans to overgrow. And once this overgrowth occurs, the organisms then invade the tissue, the superficial tissue. It's a very superficial invasion, but it's clearly an invasion. And the host responds to the new pathogen that is now germinating, forming hyphae, as well as invading, with an inflammatory response. It is the inflammatory response, I repeat, the host inflammatory response that results in the symptoms of a Candida vaginitis episode. Next slide, please. So it's important to recognize that not all women will become colonized. Some women go through an entire life of 90 years, 100 years, and never become colonized. Other women become rapidly colonized. This fundamental difference is due to a genetic predisposition or susceptibility. Whether a woman will receive a single yeast infection or multiple infections in a lifetime depends on the genetic dose that results and facilitates mainly the colonization process. Once colonized, there are triggers that will result in the transformation of asymptomatic colonization to symptomatic inflammation. What are these triggers? It may be a course of antibiotics, and this may apply to every and any antibiotic. The use of topical or systemic therapy. If a patient goes on to oral contraceptives or receives estrogen therapy, this acts as a trigger. It takes asymptomatic colonization to symptomatic overgrowth with inflammation. Among the behavioral factors that facilitate not so much colonization, but symptomatic disease, may be in fact sexual activity, excessive use of or consumption of refined sugars. These are triggers that actually are a direct and most important susceptibility factor is in fact genetics. So it follows that when we treat a patient with an antifungal agent, we are reducing the numbers of yeast in the vagina. We start off by reducing the yeast numbers within the vagina, within the lumen, within the secretions, and within a matter of days, we reduce the numbers that have invaded the tissues. We do not, by giving a course of antifungal disease, no matter what antifungal you use, whether it's topical or by mouth, systemically, you are not changing the genetic susceptibility. You are not going to prevent the patient from becoming recolonized once the treatment effect is removed. So as soon as you finish the fluconazole or you finish the clotrimazole or whatever antifungal you use, and the patient is now asymptomatic, they will become recolonized because they are genetically predisposed to becoming recolonized. Whether they get another attack or not depends on triggers and the dose of the genetic susceptibility. Next slide, please. So these triggers include antibiotics, coexistent vaginitis. Women that have bacterial infections of the vagina, bacterial vaginosis, will also have an increased susceptibility to symptomatic Candida vaginitis. Sexual activity in its own right, the physical effects of sexual activity can trigger a yeast infection. And then the other triggers are well known to you in relation to dietary factors, excessive sugars, steroids, estrogens, and so on. Next slide, please. Next slide, please. So this is a biopsy of a woman with Candida vaginitis, and you can see that the pink color in the right-hand slide and the yellow evidence of the hypha that are invading the superficial layers of the these are biopsies of women who have acute Candida vaginitis. So the drugs first act on the lumen, and then they eventually will penetrate the vaginal mucosa as they eradicate the yeast and in the process of relieving symptoms. Next slide. So we talk about if we talk about an acute episode of Candida vaginitis, a woman is symptomatic with typical symptoms of itching, erythema, edema, and abnormal discharge. We tend to divide these attacks into complicated and uncomplicated. The majority of acute attacks are uncomplicated. And we treat uncomplicated acute with either a topical agent or an oral agent. Oral agents are always preferred by women worldwide. And in this sense, the market is dominated by the use of fluconazole. We use 1 tablet of 150 milligrams of fluconazole for an acute episode of Candida vaginitis. If it's a severe episode, then we increase the number of tablets from 1 to 2 or to 3 tablets in order to eradicate the severe symptoms that may exist. Fluconazole, because it is now generic, has become inexpensive. And over 30 years of its use, it has been shown to be extremely safe, well tolerated. We do not prescribe fluconazole in pregnancy. And of concern has been an increase in fluconazole resistance, even among the common yeast infection, yeast pathogens, Candida albicans. Next slide, please. So in this figure, you can see the red refers to a patient's signs and symptoms. The yellow bar right on the left-hand side of the slide refers to the culture status. So a patient is symptomatic, is culture positive. We start with the brown, which is the treatment with any drug. And within a matter of a day or two, the symptoms start to improve. And the cultures will become negative. But they will become positive again in a matter of days. In order to prevent the recolonization, I developed in 2004 a regimen in which fluconazole would be given repeatedly. All those arrows represents a weekly dose of fluconazole that is given for 6 months. And by giving these repeated doses of the safe, inexpensive fluconazole once a week, it prevents recolonization. And if you prevent recolonization, you prevent recurrent attacks of Candida vaginitis, you prevent recurrent symptoms, and the patient returns to a totally normal life free of yeast infections. Next slide, please. However, when you stop the fluconazole, once the drug effects are over, you do not change the genes. And so it's within a matter of weeks or months, the patient will become recolonized with Candida. And once recolonized, they become at risk of getting more attacks. And in this slide, we show the effects in women who have recurrent Candida vaginitis. And as you can see, here is the patient. These are patients, 100% of the patients who have Candida vaginitis, they're symptomatic. If we put them onto a placebo, within a week, we can see some of the patients have now become symptomatic. And over the next few weeks, they have more and more attacks, and fewer and fewer of the women are symptomatic. If we keep the woman on fluconazole once weekly for 6 months, these are 6 months, you can see they remain attack-free and entirely free of symptoms, whereas more than 50% in the placebo have had a recurrence. But once we stop the fluconazole, because we do not affect the genes with the fluconazole, they will become recolonized and have the potential. But they are still a small number who are actually cured. Next slide, please. So there are different protocols. I use fluconazole once a week. Others like to give it twice a month in different doses. But the most widely used dose is 150 milligrams once weekly after an induction regimen. You've got to give them a loading dose. How good is it in controlling Candida vaginitis? This regimen is greater than 90%. It's closer to 95% in controlling, not curing, controlling Candida vaginitis. But the long-term cure is not common, because as soon as you stop the drug, you haven't cured the genes. If the patient recurs once you stop the fluconazole, I put them back onto weekly fluconazole, and we've got several patients who've been on the fluconazole for many years. It's a very safe, well-tolerated drug with very few toxic side effects. There is a possibility of Candida resistance. Even Candida albicans can become resistant to fluconazole, but this occurs in way less than 10% of the patients. An attempt was made to introduce a vaccine as an alternative to fluconazole, but it was not particularly successful. So this is a vaccine failure. Next slide, please. So resistance does occur intrinsically without extensive exposure with several strains. You see it with Candida krusei. 100% of Candida krusei will be as a member of the non-albican species, will be resistant to fluconazole. Parapsilosis about half, and Candida glabrata 50 to 60% are intrinsically resistant to fluconazole. Fortunately, these combined are way less than 10% of the isolates. When it does occur, when resistance does develop in C. albicans after heavy exposure the patient receives too many courses of fluconazole, then some of the options are you can use topical intravaginal boric acid, you could use nystatin. Occasionally, some of the other topical azoles, such as clotrimazole, miconazole, econazole, will still be working, turconazole. Very often, the resistance to fluconazole resistance is also there's cross resistance to all other drugs. Amphotericin B can be made up as a 10% concentration, or flucytosine, which is very expensive. We rarely need to, but I want to talk to you today about two drugs in the pipeline, meaning they are not necessarily available commercially yet, but are around the corner. Next slide, please. Next slide, please. Before I get there, I just want to mention Candida glabrata. Candida glabrata, many question, is it really a pathogen? Can it really cause symptomatic disease? It's of low virulence in the vagina, and it very, very rarely establishes vulvitis. In other words, it may cause some sort of irritation in the vagina, discomfort, but it doesn't cause erythema and edema. And when you see those cases, it's not likely to be glabrata. But even when you get a positive culture and you find Candida glabrata, it doesn't mean it's causing the symptoms. In every patient, you have to establish causality. If you find a culture that is positive and the patient's asymptomatic, we never treat asymptomatic glabrata. We only treat when it's symptomatic. The azoles work about 50% of the time. Nystatin works 50 to 60%, boric acid 60 to 70%. But now we've got these two pipeline drugs. One is called ibrexafungerp, the other one is oteseconazole, and we'll talk about whether they can be used or not. Next slide, please. The first is ibrexafungerp. This is a new drug in a new class. It's called a triterpenoid antifungal. It works similar to the echinocandins. It's a glucan synthetase or synthase inhibitor, and it is it's also in North America called caspofungin. Very similar structure. Next slide, please. And ibrexafungerp works in a manner dissimilar, not the same. It inhibits the glucose synthase, which is important in the cell wall, whereas fluconazole would be working at a totally different level, but inhibiting the formation of ergosterol in this wall. Next slide, please. So brexafungib is recently introduced. It's been available in the United States for about 8 or 9 months. It has a broad spectrum of activity against all the Candida species. It's even active against many of the azole-resistant Candida species. It's fungicidal, and it works very well at a low pH. And as you know, in the vagina, the pH is low, so that's good. It has a half-life of about 20 hours, and it's been studied in 2 clinical studies, and which I'll tell you about now. Next slide, please. And I'd like to compare its activity. You can see in the first study called the Vanish studies, it was, these are 2 studies. You can see it was achieving a cure rate at day 10. 50 to 63% of the patients had no symptoms. They were totally asymptomatic. And in fact, the numbers of people who were asymptomatic a few days later by day 25 had increased to about 74% in the one study and 60%. This is very impressive. In a similar study, it was shown to be similar to fluconazole. So basically, this drug for acute Candida vaginitis is as good as fluconazole. Whether it's really better or not has never been shown, because in the various studies, they never compared it directly. These were in historical comparative studies, not in the direct studies. In other words, the other product is called oteseconazole, which was introduced mainly to treat recurrent Candida vaginitis. Next slide, please. This is an azole, in other words, it's a first cousin of fluconazole. It inhibits an enzyme, which is called the CYP51 inhibitor. It is much more potent in the test tube than fluconazole. It was not, and it is very active against azole-resistant strains, and its biggest advantage, it has a very long half-life. So after you give it, it remains in the tissues for a long time. Next slide, please. In the clinical studies, the first studies were called the Violet studies. One would take women with recurrent Candida vaginitis, and you would first give them an induction. This is my regimen that I introduced originally. You give 150 milligrams of fluconazole day 1, 4, and 7. The patient returns on day 10 or 14. And these patients will invariably be asymptomatic. And they were either given oteseconazole once a week for 7 days. If you were giving fluconazole, you would give it once a week for a total of 6 months. And this was followed by 11 weeks, once a week. So fluconazole would be given in the past for 6 months. Here they were giving treatment for 3 months of an initial daily for 7 days. What did they show? Next slide, please. They showed the drug was remarkably effective in preventing recurrent disease. 6% compared to 42% resistance, less than 4% compared to 40%. So, and the safety of this drug was quite remarkable. Next slide, please. So then did another study. They said, why are we giving fluconazole? Let's give, instead of giving fluconazole followed by oteseconazole, let's give it only oteseconazole. Next slide, please. And they call these studies the ultraviolet studies. So here we are, oteseconazole, and you can, so oteseconazole day 1, day 2, followed by weekly for 11 months. So it's a total of 3 months. And they compared it to placebo after an initial dose of fluconazole. Next slide, please. And you can see once more, they reduced, next slide, please. They reduced the attack rate, was remarkable. 90% reduction in both studies, greater than 90% reduction. So here was a drug that looked like it was going to replace fluconazole. Next slide, please. Unfortunately, the FDA said, no, brexafungib and oteseconazole cannot be used in pregnancy. Fluconazole is not recommended in pregnancy. None of these drugs are prescribed in pregnancy. But these 2 drugs, in contrast to fluconazole, have potentially effects on the fetus involving, certainly abrexifungib has an effect on the possible retina. And for that reason, abrexifungib is now contraindicated. This drug that was so potent is now contraindicated not only in pregnancy, but in women who are non-menopausal. In other words, if a woman is, like, you can only use this drug if the woman has had a hysterectomy, can't become pregnant, unable to become pregnant, or is postmenopausal. This is oteseconazole. Next slide, please. So these three new drugs are very useful in theory for acute VVC if a person's allergic to fluconazole, intolerant, or resistant, provided that's not in pregnancy. Next slide, please. Let's say, for example, comparing abrexifungib and fluconazole for acute Candida vaginitis. They're both single-day therapy. Fluconazole is a single dose. Abrexifungib is 2 doses. They are equivalent. One is not better than the other. Abrexifungib is much more expensive. Next slide, please. What about recurrent Candida vaginitis? Very little comparative data. Oteseconazole achieves significantly lower recurrence rates for 1 to 2 years compared to fluconazole, but it's much more expensive and it cannot be used in premenopausal women unless they've had a hysterectomy, which reduces about 80% of the women that may be eligible to receive this new drug. Next slide, please. In summary, pregnancy therapy remains a challenge. Fluconazole, no. Abrexifungib, no. Oteseconazole, no. So you use topical agents, clotrimazole, miconazole, or nystatin. Fluconazole continues with worldwide dominance as the dominant therapy, and these new agents are now have a limited advantage unless you're dealing with a fluconazole-resistant patient. I think I'll stop there and I'll be available to answer any questions. Next slide. Done.
Thank you so much, Dr. Sobel. If there are any questions, Bharat, in the chat box, or do we have the questions at the end of the session?
Ma'am, we will have the questions at the end of the session. Now we will open for the panel discussion. So I will just share the CV, ma'am.
All right. So for the panel discussion, we welcome Dr. Neena Madnani, who is a consultant dermatologist, hair specialist, and vulvologist, a dermatologist, senior consultant, and department coordinator at Hinduja Hospital, Mahim, which is also my hospital, a contributing author in several textbooks like Clinical Images in IAVDL, Textbook of Dermatology, Clinical Images in Atlas of Rheumatology. She's the co-author of the monogram on hirsutism and author of 2 chapters in the textbook on gynecology and adolescent medicine. Highly skilled in the field of vulvar disease, acne, and hair problems. And I think she has a vulval clinic in Hinduja, which is very popular. Welcome, Dr. Neena Madnani. And our other panelist is Dr. Krishna Priya Ganguly, who's a consultant gynecologist at Orchid Hospital, Delhi, and has a decade full of experience in gynecology and obstetric field. Welcome, Dr. Krishna Priya, and of course, Dr. Jack Sobel remains with us. So let's just go in. Can you share the screen, Bharat?
Yes, ma'am.
So I thought it would be most appropriate to start off with case presentations, and then everyone can give their input on these hypothetical cases.
Ma'am, is the screen visible?
No, not visible.
Yes.
Yeah, it's visible now. Thank you. So the first case is a 26-year-old married woman who presented to the outpatient with symptoms of odorless vaginal discharge, vulvar pruritus, dyspareunia, and dysuria, which she had been experiencing for 2 years. Her first attack occurred soon after she started taking the oral contraceptive pill, and she self-medicated with over-the-counter antifungal topical therapy and an intravaginal tablet. However, there was no resolution of symptoms. Next. Next slide, please. At this point, she consulted her general practitioner, and a vaginal swab was negative for Candida species, but showed group B streptococci. Her GP prescribed a course of amoxicillin, but her symptoms of itch, dyspareunia, and discharge worsened. And then she was empirically treated with 2 single doses of fluconazole, 150 milligrams. After each dose, her symptoms remitted but rapidly returned. She had almost monthly recurrences of vaginal discharge and itch for the past 2 years. Next slide. Next slide, please. And on clinical examination, she had non-specific vulvovaginal erythema extending to the labia minora and the sulcus between the labia minora and majora with the classical cheesy vaginal discharge of VVC. Next slide. So now the case is open for discussion. What investigation would one do, diagnosis, and the treatment? We'll start with Dr. Neena.
Yeah, thank you for this interesting case. And of course, initially, when you say odorless discharge, you don't think of any vulvovaginal candidiasis. You think of the other causes of vaginal discharge, like
Next
bacterial
slide,
vaginosis. But when you see a curdy discharge, the first thing that strikes you is that it's possibly a vulvovaginal candidiasis. Only thing is, why did she not respond initially to the treatment? So what I would do is I would take a pH strip and see that it is, whether it's acidic pH. Secondly, also the history says that it started after estrogen therapy. So that also acidifies the pH.
Right.
So it goes in favor of vulvovaginal candidiasis. And then, of course, I would do a sort of a smear and see if I could see the hyphae, or if I was still in doubt, I would take a culture.
Right. And Dr. Priya?
Yeah, the same thing. I agree with Dr. Neena, because the same question came to my mind also. Why did she not respond in the first place when she was given antifungal? Sometimes I've seen the vagina is so much, laden with this cheesy discharge. I'll come to this question. I'll refer this question to Dr. Sobel later on, whether it is enough to give oral, or at the same time concurrently we should give intravaginal pessaries or these gels and creams also. Because otherwise she should have actually responded in the first instance when antifungal was given to her. So
right. Dr. Sobel, why do you think she didn't respond? Or was it because she started, she was given antibiotics, so that worsened the condition?
But one thing, maybe the oral contraceptive reduced her performance level. Maybe she was already on oral contraceptives at that time.
Right.
That could be one factor in mind, yeah.
So, so the first thing is, it comes down to the world of expectations. Patients have expectations, doctors have expectations. The patient expects whatever you give her, 1 tablet, 2 tablets, is going to cure her. You don't cure Candida vaginitis forever, for lifetime, by 1 or 2 tablets, because the genetic susceptibility is going to result in recolonization, etc. So for an acute, this woman from the word go did not have acute uncomplicated Candida vaginitis. She'd had symptoms for 2 years. She had recurrent disease. She automatically falls into the category of complicated Candida vaginitis. And complicated Candida vaginitis as chronic as this is and recurrent as this, will not respond to a single tablet of fluconazole. She may get transiently better, but not dramatically. She needs a more intensive course of antifungal therapy. Remember that picture I showed you of the vaginal walls and the invasion?
Right.
So for a complicated attack like this, she needs to get at least 2 and possibly a third tablet of diflucan or fluconazole, and that should be given day 1, day 3 or 4, and then day 7. In other words, the drug persists. You get enough drug after 1 tablet that gives you effective concentrations in the vaginal secretion for 2 or 3 days. So you give it, you divide up your doses. When you're giving her the 3 tablets, she's had effective treatment for 7 days. And that would be enough to relieve her symptoms for weeks and months, not to cure her forever, because she's going to become recolonized. This patient needed to get an induction regimen, 3 tablets at 72-hour initial intervals, followed by a maintenance once-a-week course of fluconazole for 6 months. And during that 6 months period, she would have had freedom of symptoms, freedom of attacks, a totally normal life.
Thank you. Next slide, please. So we'll just revise for the audience what Dr. Jack Sobel already mentioned, the pathways implicated in the pathogenesis of vulvovaginal candidiasis. And those indicate the clinical symptoms. So first, there is adherence of the candida, followed by invasion into the vaginal cells and epithelial cells with modulation of genes expression, trigger directional hyphae formation, which then forms a mature biofilm formation, and with proliferation of yeast cells, maturation of yeast cells to hyphae form. Until such time as Dr. Sobel had mentioned, the patient is not symptomatic. Then she has an fungal overload with enrollment of inflammatory cells, irritation, pruritus, burning, curdy discharge, and a decrease in pH. And then she's a full-blown vulvovaginal candidiasis. The clinical symptoms are now manifest. Next. So let us see the Infectious Disease Society of America, the recommendations for vulvovaginal candidiasis, which were already elaborated by Dr. Jack Sobel. So we'll just go to the uncomplicated candida vulvovaginitis, just topical antifungal agents with no one agent superior to the other, either 1 dose of oral fluconazole or fluconazole given every 72 hours, as Dr. mentioned, 2 to 3 doses. This is given in severe acute, but it can also be given in uncomplicated candida vulvovaginitis to prevent recurrence. So these are the strong recommendations in severe acute candida vulvovaginitis, which is like our case was. Then, as Dr. Sobel said, for 72 hours, you give a loading dose and then you continue once a week for at least a year. In C. glabrata vulvovaginitis, the alternative is, of course, as he mentioned in his talk, intravaginal boric acid administered in a gelatin capsule, 600 milligrams daily for 14 days. And another alternative is nystatin, intravaginal suppository, 1 lakh units daily for 14 days, or topical 17% flucytosine cream, or with 3% amphotericin B cream, both of which are expensive and weekly recommended with low quality evidence. In recurrent vulvovaginitis, 10 to 14 days of induction therapy with a topical agent or oral fluconazole, followed by once a week for 6 months, strongly recommended, as Dr. Sobel has already told us. Next slide, please. So these are the other recommendations for vaginal candida by the British Association of Sexual Health, the Public Health of England, Clinical Knowledge by NICE guidelines, etc. And all of them say that all topical and oral azoles give 75% cure in the same dose that I won't repeat it again. Of course, cannot be used during pregnancy. So during pregnancy, you can only give an intravaginal dose, perhaps of clotrimazole or miconazole. And in failed vaginal candidiasis treatment, examine, investigate, do smears, and also in a recurrent proven candida patients experiencing cyclical relapse, one should then do a culture and give fluconazole or itraconazole for a longer period of time. As I said, fluconazole for 3 to 6 months orally once, or itraconazole 400 milligrams orally once a month at the expected time of the symptom. Next slide. So these are the guidelines again for vulvovaginal candidiasis treatment recommendations. There are lots of over-the-counter regimens as well, and I won't elaborate that, and prescription ones like butoconazole, turconazole, etc. And the oral agent is always, as Dr. Sobel said, fluconazole, which remains the most popular and the most effective drug which is used. Next. So in recurrent vulvovaginal candidiasis, I think we'll skip this slide because doctor has already mentioned about how you give it for a longer period of time, 1, 4, and etc. And then for a longer period of a month, at least a year, where you give 3, initially, of course, loading dose of 3 doses, and then a maintenance of antifungal therapy can be given once a week for almost 6 months, but can be given for a year as well. As he mentioned very rightly, that these women are genetically predisposed to get recurrent infections because they have a predisposition, and they should be given a longer period of treatment so that to prevent recurrence. Next. And to prevent a load. So in this patient, case, the treatment was, the patient was given oral fluconazole 150 milligrams per day for 14 days, followed by 150 milligrams once a week for 6 months. I think this was over treatment. It could have been only for 3 days, and the patient gradually became asymptomatic for over 3 months course of continuous treatment with oral fluconazole. I think we'll go to the next case. The second case is a 38-year-old Gravida 3 para 2 woman presenting with persistent malodorous vaginal discharge with irritation, persistent pruritus, burning, and dysuria of 6 months duration. She had a previous history of treatment with a 2 grams single dose of metronidazole, 500 milligrams metronidazole twice a day for 7 days, and 500 milligrams metronidazole twice a day for 7 days, and no improvement was seen with any of these regimens. On clinical examination, she had vulvar and vaginal edema and erythema, punctate hemorrhages visible on the cervix and vagina, like strawberry cervix, and also the presence of frothy, purulent, and foul-smelling discharge. Next. So what investigations would you do? What is the diagnosis and treatment? Dr. Nina?
Okay. So I must say that your cases are really very complicated, because
these are the cases
when
we
you
see.
give the history, you can immediately, when you've described it, I say, okay, it's trichomoniasis. But then when you've given the treatment and it's not responding, so that's another dilemma. So they're great
Next
cases.
slide, yeah. Right.
So of course, because trichomoniasis is one of the sexually transmitted infections, we have to rule out the other sexually transmitted infections. So we have to check for all these which you have mentioned. And if we do a wet preparation, which I'm sad to say many of us don't do, but you would find the motile trichomonas because you had to do it immediately. If you send it to the lab, it's not going to show the motility. So your test will come negative. And of course, for trichomoniasis, the pH will be more alkaline, not acidic. So, I mean, it'll be non-acidic. So it will not be, it'll be more than 4.5. So that is what you mentioned. And I think everyone looks at the pH and the wet mount as one of the very diagnostic tests. But if you still want to go further, then you culture it. And then you have the more advanced tests.
Right, next. So the diagnosis, all regimens resulted in clinical failure and persistence of symptoms. It was therefore determined that the patient had clinically resistant trichomoniasis. So Dr. Priya, how would we treat this patient?
The patient was given metronidazole.
Next slide. Yeah.
Yeah, and the husband was probably treated in that case. So she was the trichomoral vaginitis was not getting cured because in this case, because it's an sexually transmitted infection, you have to treat both the partners. So I think it was one reason why it became resistant and the infection came back to her and she was not getting cured. So we have to direct the treatment with both the partners, I believe.
Right. The most important point, but the partner was not treated. Yeah.
Yeah.
So just a little about the pathogenesis. Trichomonas vaginalis is an anaerobic flagellated parasite which normally exists as a trophozoite, but sporadically in amoeboid form. It's a sexually transmitted disease, as we know, and human beings are the only host. It's almost always an STD, and its prevalence correlates with the overall sexual activity. And it is associated with adverse pregnancy outcomes like PROM and preterm labor. Next. Now, interestingly, studies have found that 70% of men having intercourse with infected women demonstrate the disease in 48 hours. While if the reverse occurs, 85% of the women contract the infection. And there's a high prevalence of gonorrhea in these women. And condoms, spermicidal agents, barrier contraceptives are thought to reduce transmission. Infections range from asymptomatic to severe. Vaginal discharge is reported in almost 50 to 75% of patients, and they are usually a classic yellowish-green frothy type to a grayish, or sometimes they don't have any discharge. Other symptoms include vulvovaginal soreness, irritation, pruritus, dysuria, malodorous discharge, and dyspareunia. Next. So the pathogenesis is, of course, the adherence of the virulent T. vaginalis to the vaginal and epithelial cells, which then there is activation of adhesions, proteolytic degradation of mucosal layer, fishy amine vaginal odor, and homogeneous thin discharge. Then there's elongation of the T. vaginalis with the formation of pseudopods which interdigitate at the site of contact, and host immunity's invasion. And then with growth and proliferation, of course, we have enrollment of other T. vaginalises through chemoattractants, and there is phagocytosis of the lactobacillus. There's fall in the lactobacillus, vaginal pH increases, and sometimes there's blister synthesis. Next. So the treatment recommendations by the CDC USA is the recommended regimen is metronidazole 2 grams orally in a single dose, or tinidazole 2 grams orally in a single dose. Alternatively, metronidazole 500 milligrams orally twice a day for 7 days. And recommended regimen for women with HIV infection would be the same, twice a day for 7 days. Next. The other recommendations from British Association and NICE guidelines would be treat both the partners and refer to a sexual health services. Metronidazole, of course, 400 milligrams BD or 2 grams for 5 to 7 days. In pregnancy, breastfeeding, avoid metronidazole. Consider clotrimazole for symptomatic relief in a pessary for 6 nights. Next. So this patient received 500 milligrams tinidazole 3 times a day oral treatment, which was initiated for 7 days. And her husband was treated with 500 milligrams of metronidazole twice a day for 7 days, with instructions to use barrier contraception. He was asymptomatic throughout. Follow-up examination 14 days after therapy. The patient had resolution of all the symptoms, a negative bed prep finding for trichomonas, and again, there was no recurrence at 1 month post-treatment. Dr. Ganguly, would you say that this patient, should we give a little long-term therapy, as Dr. Sobel said, for recurrent vagina, or this would be treated only if she has symptoms again?
Yeah,
would we give a preventive?
In this case, because both of them haven't given adequate treatment for 7 days, I don't think long-term treatment in this particular case is warranted. And also they have been advised to use barrier method while doing intercourse. So I don't think at this point of time that you require a long-term treatment for for trichomoral vaginitis for this patient. But of course, the patient has to be kept upon follow-up. Like you said, after 14 days, they saw the resolution of symptoms had occurred. And the patient would be directed to keep proper hygiene, and the husband also the same thing. In this case, I think we can stop the treatment after 7 days. If there's
Right.
no...
Right, thank you. Dr. Sobel, your views on the case?
So,
Next slide, please. Next slide.
The most important thing about the patient, before we come to patient number 3, is that initially for case number 2, the pH, an elevated pH is crucial in these patients, and it tips you off because Candida vaginitis, the pH would be normal in the majority of patients. But a high pH could either be due to trichomonas or due to bacterial vaginosis. And bacterial vaginosis is far more common than trichomoniasis. But that's number 1. Number 2, we have replaced the culture method for trichomonas in those patients who are microscopy negative with a molecular test called a PCR, which, although more expensive, is phenomenally more sensitive and reliable. And therefore, PCR, I am not a great fan of molecular tests. You don't want to recommend tests that cost a lot of money and then are not available. But Trichomonas PCR is so much more reliable. Now, if you see the motile organisms, that's another story. But in a patient who has a foul-smelling discharge, lots of white cells and high pH, where that is microscopy negative for trichomonas, you must do a PCR test. Secondly, we have stopped using single-dose therapy for women with trichomonas. We now routinely give 500 milligrams BID for 1 week. That's now the standard of care. Recurrences in women with trichomonas are more common with single-dose therapy. The biggest challenge, all right, so let's go now move to case number 3.
Case number 3. So case number 3 was a 28-year-old woman whose main occupation was housekeeping, visited the midwifery clinic with vaginal infection. She had vulvovaginal itching, burning, soreness, abnormal vaginal odor, discharge, and lower abdominal pain. She was married for 2 years, and in the past 2 years of her marriage, she visited the clinics many times due to vaginal problems, the similar problems. She had dyspareunia also. She had received 150 milligrams of clindamycin tablets, 1% clotrimazole cream, antibiotic vaginal cream to treat her infection. But since her husband was not treated, all the clinical signs appeared again within a short time. She had a spontaneous miscarriage. Her husband was found to be asymptomatic. On clinical examination, she had low abdominal tenderness. She had a patchy macular erythematous lesion of the cervix and yellowish green foamy secretion. Uterine hemorrhage, dyspareunia and redness and edema of the lower end of the uterus, whatever that is. I mean, on the cervix, most probably chronic cervicitis. And the vaginal pH was 5.5. Next slide. So what are the observations, investigations, differential diagnosis and treatment of this case? We'll start with Nina.
Yeah. So
Next
again,
slide,
one of
please.
your complex,
Yeah.
one of your
All of
complex
them
cases.
are complex, yeah.
Yeah. So when you listen to the history and the investigations, 2-3 things come into mind. One is that patient is very symptomatic. Patient has had recurrence. Patient has had negative outcomes in her pregnancies. And also the other thing which struck me is that you said that she had a frothy green and her pH was more than 4.5. So we again looking at just the pH more than 4.5, frothy green, very symptomatic, then again you only can think of trichomoniasis, because that is because the other infections more than 4.5 is bacterial vaginosis, and that doesn't give you so many symptoms. Or it could be a mixed infection, but then you have given her the syndromic treatment But in the syndromic treatment, it's a single dose of tinidazole. So maybe from our previous discussion, she has not had adequate. So these are my observations.
Next slide. So that comes to our next topic, I think, Dr. Ganguly, is that the World Health Organization recommends syndromic management of vaginal discharge in a low resource setting. And Dr. Sobel, ours would definitely be, at least may not be in the urban India, but most of India, we have low resource setting. So doing a culture or even a PCR for trichomoniasis would be much more expensive than just giving her a cheap treatment of tinidazole or the metronidazole for 500 milligrams BD for 7 days. That would be, an empiric treatment which we could do, and leave perhaps the PCR for recurrent cases. Next. So these are the guidelines, and this is the flow chart. I think once a patient complains, then if you find that there's an abnormal discharge, you educate, counsel, and promote providing condoms and other HIV counseling. Then if there's lower pain, use a flow chart, treat for, do a pH test, you can do a KH test also, treat for chlamydia, trachomatis, gonorrhea infection, etc. If you feel that there's a discharge, treat for bacterial vaginosis, trichomonas, vaginitis, treat for, if there's vulval edema, curd-like discharge, erythema, treat for fungal infections and Candida albicans. And if also education counsel, always treat the partner as well. So in this syndromic management, your clinical perception is of the problem would be the diagnosis. So you find the kind of discharge, you can do the pH test, which can be done. You can do the wet smear, that also can be done in the clinic, but more detailed tests like cultures, etc. They could be sent, patient could be started with the treatment, and we could do it later. Next slide. So the advantages, of course, of the syndromic management are the care is given very fast. It's the treatment at the first visit. Your cost is saved by avoiding expensive laboratory tests, and increased patient satisfaction, no risk of losing the patient to follow up before starting the treatment. So you start the treatment, and then, of course, follow her up with her when her culture reports come. Next. So the case number 3 was treated with fluconazole 150 milligrams orally every 3rd day for 3 doses. She received azithromycin 500 milligrams stat, 2 tablets of dexamethasone stat, and concurrent treatment was given to her husband. And I think this is the standard treatment that we do in all our clinics. Next. So I think this, we'll skip the slide. This is the summary of slides and signs and symptoms of infective causes of vaginal discharge. So this is for syndromic. If you see a discharge which is thin, it's bacterial vaginosis. If it's thick white, it's candida. If it's scanty to profuse, trichomonas. If the odor is offensive and fishy, it could be bacterial vaginitis. It could be trichomonasis. Candida, unless it's a mixed infection, is not usually odorless. Itching, none in bacterial vaginitis. There's a severe itch in candida as well as trichomonal. And other symptoms, of course, like soreness, superficial dyspareunia, dysuria, low abdominal pain. And visible signs would be discharge coating the vagina and vestibule, and no vulval inflammation and bacterial vaginosis. In candida, there would be normal findings, so you'd find vulval erythema, edema, fissuring, and satellite lesions. And in trichomonas, you get the frothy yellow discharge with vulvitis, vaginitis, cervicitis, the strawberry cervix that you see. And the pH, of course, the most important, as Dr. Sobel mentioned, is less than 4 in bacterial vaginosis, equal to 4.5 in candidiasis, and more than 4.5 in trichomoniasis. Next. So this is the same thing, the algorithm. I think we'll skip this. Next slide, please. And we'll skip this. This is just the 3 common recurrent vaginal infections: bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. Next. So then we come to the case number 4, which is the last case. And this is the 37-year-old female teacher who presented to the outpatient with complaints of vaginal pruritus since 1 month. She had no medical history. She had heavy cottage cheese-like vaginal discharge. Bilateral labia majora were thickened. The vaginal discharge was tested for chlamydia, Neisseria gonorrhea, mycoplasma species. I think this vaginal discharge, it should have been a cervical swab, which was tested for chlamydia and Neisseria, of which all were negative. However, a fungal culture was positive. Thus, monilial vaginitis was considered, and clotrimazole cream and tablet fluconazole in a single dose were prescribed. But 2 weeks later, she returned with a new onset of burning sensation along the urethra, edema of the labia, increasing tenderness of the external genitalia, and her pruritus had subsided. On clinical examination, she had swollen genitals with clustered, punctate, painful erosions between the labia with small, thin amount of vaginal discharge. The vaginal examination could not be done because of severe soreness. The patient was afebrile, oriented with no other general manifestation of infection. Next. So again, investigations, diagnosis, and treatment. Another complicated case, Nina. You're muted. You're muted.
Sorry. So
Next
this
slide,
case,
yeah.
So this case actually proves to us that a woman can have multiple infections over her lifetime. And this episode, which you talk about, of course, with the punctate, multiple painful ulcers, 2 things come in mind. One is because it's acute, it can be herpes. And second is we have to also think of chancroid. These are the 2 differential diagnoses which one would keep in mind for multiple grouped painful ulcers on the vulva. So these 2 would come into mind. What would I do for diagnosis? The diagnosis of herpes is so stark. The clinical examination itself and the history, the patient complains of severe pain. What I would do as investigation is I would maybe do a zinc smear, and I would see the multinucleated giant cells. Beyond that, I would not even do the serological testing.
Absolutely.
Because so many patients are positive. They've had a past history of herpes. So for me, the most important would be clinical and a zinc smear to prove a diagnosis of herpes. And
Right.
chancroid is also exclusion. So you exclude the herpes and you think of chancroid, and then you do the various tests for chancroid.
Right. Next slide, please. So, anything to add, Dr. Ganguly?
This case, the interesting thing was that in the beginning, the herpetic lesions were not visible. There could have been an element of fungal infection. So that subsided and the patient again came back with pain and all. So it could be again a case of mixed infection. But normally I can't say whether fungal and viral infection, they go hand in hand. Because eventually though they saw the ulcers, herpetic ulcers, and the patient had to finally put on acyclovir probably. So this is what is confusing, why in the beginning the signs were something else, and after some time, it took some time for the herpetic lesions to appear. Why this gap was there, this I'm unable to understand.
And both were STDs, perhaps, so she had both.
Yeah,
or subsequently, her fungal infection predisposed her to get a herpetic infection.
Exactly. I think
That could be possible.
That could be.
Yeah, next slide. So WHO recommendations acyclovir as the first line of the management of genital herpes and recurrent infections. Next. I think we are all aware of this. Acyclovir 200 milligrams orally 5 times a day for 7 days, or 400 milligrams orally 3 times a day for 7 days, or famciclovir 250 milligrams 3 times a day for 7 days, valciclovir 1 gram twice a day for 7 days. Topical treatment with acyclovir produces only minimal shortening and it is not recommended. So oral treatment is the gold standard. Next. In recurrent infections, most patients with the first episode of genital HSV infection will have recurrent episodes of genital lesions episodic or suppressive antiviral therapy will shorten the duration of the genital lesions. But of course, once she gets the herpes infection, it's there for life. They will benefit from antiviral treatment, and suppression should be done immediately when the prodrome, within 1 day of onset of lesions. If you give the treatment, the recurrence becomes much less, and also the episodes become much less with antiviral therapy. But these patients will have to be educated. A prescription should be given to them, and as and when they see the blisters, they should start on their own. What do you say, Dr. Sobel? What is your take on treatment for herpes genitalis?
You've summarized it perfectly adequately. Once there's a history, firstly, when the person presents with ulceration, the optimal test is not a serological test. The optimal test is a PCR. A PCR, you'll get the results within 24 hours, and it'll tell you, and it is the highest sensitivity, and you don't wait for the serology. So in the presence of acute lesions, you do the PCR swab on the lesions. If you see the patient who just gives you a history of recurrent ulceration, then you do the serology. The serology is of value when you're not seeing acute lesions. And or if you see the patient late and the ulcerations have already healed and there's nothing, then you do the serology, because the PCR will now be negative. Now I understand the PCR is an expensive test, but getting serology is also expensive, is not cheap. Right. The standard of treatment you've given, the various regimens, are perfectly adequate and perfectly acceptable. And when you have recurrent disease, you have two options. If the patient patient is capable of recognizing symptoms very early on, especially 24 to 48 hours before the lesions appear, but they start to develop pain or irritation, then you can abort the attack by using either acyclovir or famciclovir or valciclovir as a means. So you're treating each episode and you prevent the worsening. You try to abort the attack by starting treatment immediately. If you're unable to do this, which is quite frequent, if the person's having 3 or more attacks per year, it is cheaper in the long run to put them onto a maintenance program with either acyclovir or famciclovir or valciclovir, but now you're taking daily therapy for 3 or more attacks per year.
Right. Another point is, as an obstetrician, if a patient has active lesions, then she has to have a planned cesarean section without rupture of the membranes. And that's very important. Otherwise, the neonate, as it's passing through the passage, will get neonatal herpes.
Right.
Next slide. So that's the suppressive therapy, which I think you have already mentioned, so we won't go through that. Next. So this patient's partner was advised to undergo testing. She was treated with acyclovir for 14 days at a dosage of 200 milligrams 3 times a day for 10 days and a mild analgesic for the pain. 2 days later, the patient complained of urgent urination with dysuria, no fever, but urine analysis showed a strong positivity for leukocytes, and she developed a urinary tract infection and was administered ceftriaxone 250 milligrams twice a day for 4 days. And on the 8th days, not hospitalization, but after 8 days, the antibodies tested negative. Next. Next.
Can I make a comment?
Yes,
Can
sure.
I make a comment on that last slide?
Right.
So normally when a patient gets an acute attack, if we do a serology, the IgM, it rises only after the 10th day of the attack. And the IgM, after a couple of weeks, it starts, right? IgG, after a couple of weeks, it starts rising. But what is important is that the IgG cannot come down to negative in 8 days. It takes weeks and months for the IgG to come down to normal. So this is very surprising that on day 8
that's
she
what I'm
was
saying.
negative.
This I think this last one should not be there because she was not even hospitalized. And also one should not administer any antibiotic without a urine culture and sensitivity.
I was also what is happening here. But
right. This is a bit of a googly slide. We'll go to the questions that some of you have posed for Dr. Jack Sobel. So this is a question for you, Dr. Sobel. Is it necessary to do a culture test for every patient with vaginal discharge? And or is it required only in case of recurrent candidiasis?
So let me answer the second question first. Is it no, if a patient has recurrent candida vaginitis, the treatment is to put her onto an induction and maintenance program for several months, regardless of the species, etc. You do not want to put anybody onto a maintenance program, fluconazole or otherwise, without having culture confirmation of the diagnosis. So for recurrent disease, always have a culture confirmation to confirm both the diagnosis and determine the species. Now, let's go back to the first question here. Is it necessary to do a culture test for every patient with a vaginal discharge? Now, I am old school, and I do a pH on every patient. I do a physical exam on every patient, and I do a microscopy on every patient. And microscopy is not expensive. It takes time, yes, but if you have and what we need is we have an obligation to our patients to make a right diagnosis. Every woman I see, I do microscopy, pH, and culture, and microscopy and pH. Culture, it depends on what you're dealing. If you have a high pH and you're suspecting trichomonas or BV, bacterial vaginosis, then I would not do a yeast culture. It's not essential. It is not essential. And anyway, if a person has a normal pH, then you must be thinking about Candida. That's the patient in whom you do microscopy. If the microscopy is positive and you see hyphae and blastospores and budding yeast, then you don't have to do a culture every time. But if your microscopy is negative and the patient is clinically abnormal and the pH is normal, then you have to make a diagnosis. Nobody should leave your office without a diagnosis. Vaginal discharge is not a diagnosis.
Right, thank you. The next question is, I think, from from Dr. Ganguly to you. Have you come across patients who have premenstrual flares?
Absolutely. Yeast infections, Candida vaginitis, typically when they present spontaneously, I'm not talking about somebody who's taking a course of antibiotics. If a patient takes ampicillin or amoxicillin or cephalosporins, tetracycline, doxycycline, and they get an attack of Candida vaginitis, it can occur anytime. But it's the women who have chronic disease and recurrent disease where you're getting attacks that occur without another trigger. It typically occurs in the week prior to the onset of menses. So its typical premenstrual flares is very, very suggestive. Bacterial vaginosis, trichomonas, does not flare premenstrually. They flare intramenstrually and postmenstrually. So just taking that history is very, very useful. The same way I take it, when I take a history, I ask the patient, does your partner, your male partner, ever develop symptoms? And in women with recurrent Candida vaginitis, their male partners will react to the presence of Candida and the vaginal secretions, and they get a balanitis. A balanitis is in the male partners, and it usually resolves within a matter of 48 to 72 hours, often a little bit longer. And therefore, I often have men phone me and say, you must see my wife. She's got recurrent yeast infections, recurrent candida. They're back again. I think she needs to go on to maintenance fluconazole. And I'll say, why are you calling me? He says, well, we had intercourse 48 hours ago, and I'm now got an erythematous glans penis. And he says, your wife symptomatic? No, she doesn't have symptoms, but I have symptoms. He is developing symptoms in response to the presence of the candida in the vaginal secretions of the woman, even though she is asymptomatic. So take a history, examine your patients, measure the pH, do microscopy.
Thank you. And the last question is, I think, from Dr. Nina. How often is it required to prescribe newer antifungals like voriconazole? Is it required?
Before excuse me, Dr. Sobel, before you answer this question, can I go back to your last answer?
Yes, of course.
So when the man develops a balanitis,
Yes.
is it a candidial balanitis or is it an irritant balanitis? What is it?
Most commonly, it's a candida balanitis.
So we need to treat the man?
Yes, but with I usually give them a topical cream, and within 24 hours, they're fine. The most inexpensive topical therapy. So back to the question of voriconazole. The voriconazole is very potent. It is no more active against most strains of Candida albicans than fluconazole, clotrimazole, etc. If the organism is resistant, if you have Candida albicans, and it's not common, but if you have Candida albicans that is resistant to fluconazole, then you can consider voriconazole. But there are many other alternatives. Voriconazole is not cheap. Voriconazole is a medication that has numerous side effects. We don't know the optimal dose. It's never been studied. It's used rarely. If you do a literature search, you'll find in the entire literature of billions of articles, there are about 2 or 3 articles of voriconazole has been used. Sometimes it fails, sometimes it's successful. I never use voriconazole. It's not a simple drug. It's not a drug that is inexpensive, and it's not a drug that doesn't have side effects. If you have a yeast that you know is there, the cultures are positive, and it's not responding to an azole, such as fluconazole, then you can use nystatin, preferably to voriconazole. You can use boric acid, which is preferable to voriconazole. And so it's very rare to use voriconazole. Maybe once in a lifetime. I want to see.
Yeah, thank you. I think, Bharat, I think we can answer the audience questions now.
Yes,
is there
ma'am.
anything
Yes,
on
ma'am.
the chat box? Yeah.
Yes, ma'am. Just a minute. But there are a few questions which I'm just dropping out in the chat box, ma'am.
Yeah.
Ma'am, this is the first question I've just posted in the chat box, ma'am. Yes, ma'am. Yes, ma'am.
Yeah, this is for Dr. Sobel. A patient with no vaginal discharge, but having burning after intercourse and after passing urine. What would be the diagnosis?
So you first you can't make the diagnosis on the history.
Yeah,
We
exactly. Without
never.
examination.
You know, the whole world says you can make a diagnosis by doing telemedicine. The modern answer to the world's problems is telemedicine. You can't make a diagnosis by history. Number one, the first thing is you need to examine the patient after intercourse. See, has there trauma? Has there been a minor traumatic fissure, etc.? She could have burning if she's estrogen deficient. Many people are estrogen deficient. Many of the lower, so there are many causes of non-infectious post-coital, post-intercourse burning can be caused by infectious causes and non-infectious causes. The first non-infectious cause, first infectious cause is Candida. Many women will have burning after intercourse with Candida without a discharge. There's nothing magical about the discharge. You can't look at the discharge. I want to repeat this. You can't look at the discharge and say, oh, you have Candida. B, you don't have Candida. The discharge can be clumpy for Candida. It can be quite liquidy for Candida. You can't look at the discharge. If you think you're going to bypass pH in the microscopy and diagnose it by looking at the discharge, you'll get some rights. You'll get many wrong. So firstly, the absence of a discharge does not exclude an infectious cause. It does not exclude Candida. You get a vaginal swab from a physical exam, you examine the patient and you send it for culture. Some women are especially as women get postmenopausal, they start getting estrogen deficiency, they start getting thinning, they have intercourse, they dry, they are thin, they get postcoital irritation and burning, common. And I can list another half a dozen causes. You need a diagnosis. You know what they say? One man, one vote, one woman, one vote. One woman, you get a diagnosis every single time.
Which comes to the next question on the chat box, is that many young girls who are not sexually active have thick, curdy vaginal discharge.
Correct. It's physiologic. You can't look at a discharge and say it's abnormal. You reassure the patients and say, we do not want to overdiagnose Candida. Sexual activity has nothing to do with onset of Candida. Many young girls, young women, even before, just before the year or so before the onset of periods, will start getting Candida, getting enough estrogen in the year before they start with the frank menses, or as soon as the menses start, they start to get developing symptoms. It has nothing to do with the discharge. Forget about diagnosing discharge with anything on the basis of a discharge. You'll be wrong as often as you are right.
And I think for these young girls, this is the answer to the question, is that menstrual hygiene and local hygiene is very important. Wearing cotton underwear, no underwear to sleep at night, good pH balanced washes for local wash, all that is important. Not where I always feel in India, at least, jeans are a girl's worst enemy because they wear these tight jeans, there's no ventilation. And, nylon underwear, all these things contribute to recurrent vaginal infections in these young girls. What would you say?
No problem. No. But remember, you start talking about behavioral the hygiene factors only when you know the cultures are negative and you examine the patients. You don't, and it's always, there's no alternative to doing a thorough physical examination. No alternative.
And another thing is that someone asked is that, pinworms, etc., may also cause pruritus. So one should always do a little bit of a wet swab on the rectum and send for pinworms. Yeah.
Excellent. Correct.
Any more questions?
You're exactly wise and right.
I think we're done.
Just one last question, ma'am. Actually, Mrs. Bharati Chavan has asked a question on the dose of fluconazole, 150 or 400 mg.
I think that was answered by Dr. Jack Sobel.
Yeah, that's it, ma'am. We are come to the end of this session. And I thank you, Dr. Jack Sobel, for such a wonderful and elaborate presentation. Sir, you had really emphasized on the most crucial part of when it comes to the vulvovaginal infections, which is the diagnosis. Thanks again, sir, for sharing your clinical perspective on fluconazole based on your clinical efficacy, price sensitivity, and the dosage based on the severity. Finally, thank you, sir, for throwing light on the newer antifungals which are emerging in the management of VVC. Yet, still there are certain limitations, but till the time fluconazole role remains unchallenged, I thank Dr. Kiran Coelho for wonderfully moderating this session. Ma'am, all of your case studies were very brilliant. And ma'am, it was really backed up by various international guidelines and treatment regimens. And also from most of your case studies which you had presented, ma'am, one thing was very clear. The role of fluconazole is really promising. And also I thank Dr. Neena ma'am and Dr. Krishna Priya Ganguly individually for your microscopic investigations, diagnosis part and treatment part. Ma'am, you both have taken it wonderfully. And finally, I thank all the doctors who have attended this session and looking forward for more such interactive sessions. Till the time, thank you so much, everyone. Thank you, Neena ma'am. Thank you, Dr.
Thank
Jack
you.
Sobel. Thank you, Dr. Kiran Coelho, and thank you,
Thank you.
Dr. Krishna Priya Ganguly. Thank you.
Thank you for
Thank
the
you.
opportunity to listen to Dr. Sobel and interaction with all my colleagues. Thank you.
Thank you so much.
Thank you
Bye.
very much.